Chapter 18, Pain Management for Childbirth. The two components of pain during birth include 1, a physiological component, and 2, a psychological component. The physiological component deals with how the woman reacts to the pain she is experiencing. Childbirth pain differs than normal pain in various ways, including the pain is not constant. The woman has time to prepare for the pain during pregnancy, and at the end of the pain, she has the birth of a child. Physical pain that is felt during labor is due to the tissue ischemia that occurs with the loss of blood flow to the uterus during contractions. It also occurs from the cervical dilatation and pulling and pressure on the pelvic structures. The last physical component is due to distension of the vagina and the perineum. The characteristics of the pain can determine how the woman handles it. Fatigue can make the pain seem worse. The fetal position can make the pain worse as well. Are we doing an intervention to help with the pain? For example, changing positions can sometimes lessen the pain. There are also a variety of psychosocial factors that will affect pain as well. Culture can play a part in this. In many cultures, women are stoic and they will not ask for pain meds, or the man will take the decision if she needs something. Anxiety and fear can cause the pain to become intense as well. It doesn't allow her to relax. Previous experience with pain can also make it hard to deal with the pain. Childbirth education classes can sometimes help with the pain as they teach non-pharmacological measures to deal with the pain. Also, having a good support system can also help a woman deal with the pain. Some women choose to use non-pharmacological pain management throughout labor, or some women will use it during the early stages of labor. There are advantages, which include they don't have side effects and there's no risk to the mom or the fetus. Sometimes they will use these measures along with pharmacological measures. The limitations include they may not be effective for the pain. It is ideal to prepare for these measures before labor starts. Practicing during pregnancy can help with them prepare during labor. If they did not prepare, then it's ideal to prepare during the latent phase of labor before that pain becomes too intense. General comfort measures can include keeping the room dimly lit, the quiet environment, maintaining a comfortable position are a few ways. Reducing anxiety and fear can be done many times just by keeping the woman updated on the plan of care. Keeping her informed can help her relax. Relaxation can be obtained by using music, low lights, massage, soft touch. Mind-body stimulation can be effleurage, which is a self-massage on the abdomen, legs, or wherever it helps the woman relax. Warm packs on their back can help, or acupuncture is preferred for some women. Hydrotherapy involves using a tub or shower to provide relief and relaxation. Mental stimulation can be a guided imagery where woman closes her eyes and imagines she's at her favorite place. She can see the sights, smell the smells, and feel the environment. They can use a focal point for focus on each contraction and think about that item each time she's having a contraction instead of the pain that she's experiencing. Breathing exercises can be very effective for some women. They may use them during early labor or throughout the whole labor process. There's no wrong way to do the exercises, so I'm going to be very brief on these. During what they call the first stage of breathing exercises, the woman will take a big cleansing breath where she fills her lungs with extra oxygen and exhales. Then she focused on paced breathing. When the pain is not as bad, it typically is a slow paced breathing. As the pain intensifies, it becomes more modified paced breathing. Her pace picks up, but she's still remaining in control and trying to follow a pattern. Common problems with breathing is she can hyperventilate if she's breathing too fast. She would start to feel dizzy and some numbness or tingling in her extremities. Having her slow down her breathing and breathe into a paper bag or her cupped hands can help the situation. Second stage breathing helps her with the pushing process. It's used to be so they would have to hold her breath and count to 10 while pushing. This can cause vasoconstriction and decrease the blood pressure, so now they encourage the open glottis pushing. She doesn't have to scream with each push, but grunting or groaning can help. Effects on the fetus from pharmacological pain management includes direct effect and non-direct effect. The direct effect is when the medication crosses the placenta and enters into the fetus bloodstream and can cause a decrease in that fetal heart rate or the variability. An indirect effect is when the medication affects mom and those effects are carried over to the fetus. For example, if mom gets an epidural, one of the side effects is maternal hypotension. When mom experiences hypotension, there is a decreased blood flow to the placenta, which then can cause a decrease in that fetal heart rate. Some medications can slow labor, so it should be determined she's in a good pattern before administrating. Epidurals can make it hard for a woman to push effectively at the time of birth, so many times the epidural is turned down so she can assist in the pushing efforts. Pain medication can interact with the medications or herbal products or street drugs. Getting a good history is crucial so the correct pain management can be followed. Local infiltration anesthesia is used prior to an episiotomy is performed or if repair of a laceration is needed. This type of anesthesia will not decrease uterine contraction pain. It just numbs the local area where it's injected. They are rarely have any side effects from this type of anesthesia. An epidural is a popular choice for many laboring women. It can instantly take the pain away for most women. It allows a woman to be pain-free and relaxed during the birth process. It is safe for most women. A few instances where it's not recommended would be if the woman has any coagulation defects and she has hypovolemia. If she has severe infection, then this option is also not the right choice. The biggest adverse effect is the maternal hypotension. Vasodilation can occur, and this causes the decreased blood flow to the placenta, which in turn can cause a decrease in fetal heart rate, which can cause fetal hypoxia or acidosis. Providing mom with a bolus of lactated ringers or normal saline prior to the epidural can sometimes offset the hypotension by providing the extra fluid volume that is needed. Bladder distension is also a possible side effect. This is due to the rapid fluids they give and her decrease in sensation to feel the fullness of her bladder. Intermittent or continuous catheterization is standard of care. An epidural can cause an increase in that second stage of labor as she has the decreased urge to push and may not push effectively. Turning down that dose can help with this problem. Maternal fever may also occur during this time. There's no known cause for this, but it can happen. Effects of the actual opioid medication can include nausea and vomiting, pruritus, and respiratory depression. Nursing care includes being sure the consent form is signed, providing that fluid bolus prior to administration, and good assessment and monitoring throughout the procedure to help reduce the adverse effects to mom and baby. The combined analgesics, also known as an intrathecal, it injects an opioid analgesic into the intrathecal space. Many times an epidural catheter is placed as well, so if later the woman needs more pain relief, an epidural can be administered. With the intrathecal, many women do not lose sensation like they would for an epidural, so many women can still get out of bed. It does not take away as much of the pain as an epidural, but offers good pain control. The adverse effects are the same for the opioid side effects for the epidural and include nausea and vomiting, itching, and delayed respiratory depression can occur. Nursing care includes monitoring vitals, fetal heart rate, any safety concerns, and managing any side effects that may occur. The spinal block is used for cesarean sections if the woman doesn't already have an epidural in place. The medication is given in the subarachnoid space and the woman has no sensation anywhere below that spot. She is numb and will not feel the cut from the incision, but she may feel some tugging and as they are getting baby out. Contraindications and precautions are the same with epidurals. Adverse effects include hypotension, bladder distension, and the risk for spinal headache. If a spinal headache occurs, it is from the leaking of the spinal fluid from the injection site. Bed rest and IV fluid is a treatment measure they will try first. If this is not effective, then a blood patch may be needed. 10 to 20 mL is obtained from the woman and then injected into the spinal site. Typically, immediate relief from that headache is noted.